Hello friends. So I thought it's prudent that I cover a bit on human metapneumovirus, which seems to be creating waves. So unlike maybe others narratives, this I will stick to possibly the core science that we know about this virus. So it's not about what I believe or what anyone believes. It's more about the scientific facts that are currently available about this virus. And of course, we'll have MCQs at the end of it. So friends, I think I'm sure many of you know that I had done around more than 65 videos during COVID, touching about all the science that prevails. So one thing about any sort of a virus that tends to crop up, I think we need to take the substantiation with regards to scientific facts that govern us as to how we should deal with it. And that's what we did in COVID, and we emerged victorious because science is the only way that we can vanquish any sort of a virus that may crop up at any point of time. So I'm an intensive care specialist working at Manipal Hospital, Yeshwanthpur, because this possible video many other public people may see, but this is more to do with the scientific aspects that we know about this virus. Why is it important to know about this virus? So this is the latest updated from the news because I was just going through the news. So this was just came around late night yesterday. So as you see, there are in India, as of yesterday night, midnight, 8 HMPV cases have been reported so far. So that's the sort of a burden. So it's not a huge number. Obviously, when you do more testing, more cases will be picked up. But it's a very minuscule number for a country like India at this point of time. So what about, is this an alarm globally? Because India, we have only had 8 cases for a large country like this, and which is a extremely minuscule number. But why is it that we are worried about HMPV virus at this point of time? So obviously, one has to Google and see worldwide what is happening. So this is the report from Malaysia. So in Malaysia, as you see, they have 327 HMPV, which is a 45% increase compared to total. So they have maintained their database and there has been a significant surge. That's why we have to be cognizant and vigilant about the rising numbers. So this is the sort of a numbers, at least from other countries. So there has been 45% increase. So we have to pay some attention that there has been a surge in this number. And so basically, when you talk about this particular virus, I think most of you listening to this know that this is a old virus. It has been prevailing pretty much for a long period of time, and it is present. And generally, the cases tends to increase during winter. So this has been present, first identified in Netherlands in 2001, and even there is claims from 1958 this virus has been there, and every time there is a surge in cases during winter. So this is something that we know. So this belongs to pneumoviridae. So this is a newly classified virus group from paramyxoviridae, and now they have classified it under pneumoviridae. So like in COVID, there are different strains. As of now, the strains that one is aware is A and B. And in A, they have two strains, A1 and A2, and B in B strain, they have B1 and B2. So these are the strains as of now, when we look into the literature, are the strains that are currently known. I'm sure if there is a surge in cases, the scientific body would try to recognize if there is a new strain that has evolved following certain mutations that happened in coronavirus. And when you look at the age group, I'm sure most of the listeners would know that it can occur in any age group. And every specialist on the social media would have told that the most vulnerable are the younger kids and elderly with a lot of comorbid problems, immunocompromised patients. They are the vulnerable. And so was the case in coronavirus. But somehow this HMP virus tends to have more predilection to the kids. And 2 months to 5 years is the period where more than 90% of the kids would have exposed to HMPV virus. Conventionally, they would have been exposed already. So 2 months to 5 years, close to 100% of the kids would have been exposed. But why we are talking about it, unless there is a new strain that has emerged or there is a mutated virus with more potency that may have emerged, that may cause problems. And even in Bangalore, the 2 cases, it was in kids. So that is the current sort of a clarity we have with regards to the numbers. And the spread is by droplet infection. So we'll talk a bit on what droplet infections are all about. And when you talk about symptomology, as I said, it occurs more severely in young kids. At 22 months, is the peak sort of a age group at which it has affected maximum from the studies that I have cited. So it can cause pneumonia. So as you see, it can cause pneumonia, and bronchiolitis has been reported, so which can be problematic in kids. And if someone has atopy and bronchial asthma, they can have exacerbation. So these are typically described when you look into, and there's not much body of literature when you look into PubMed and other things, there's not much data. But this is all we know, that it can cause pneumonia, it can cause bronchiolitis, it can cause if they have underlying COPD or asthma, it can cause exacerbations. And then we have seen metapneumoviruses coming to our ICU previously, like every year we see few of the patients. But I have to confess, none of them have had a severe ARDS. So, and they've had come with respiratory failure, they get better and go. So this season in my Manipal hospital, we have not seen any metapneumovirus coming to ICU. So when you look at epidemiology, like any other viral infections, the peak infections tend to happen in winter. So currently we are in a winter season and early spring. That is when it peaks. So we are in the maybe early part of the winter or in the little mid part of the winter. So this is the time we have to be vigilant, because we could expect a surge in the cases. And as I said, less than 2 years is most common for this virus to happen. And the average age where it peaks, where it affects in a peak way, is 22 months. As I've already said, in 5 to 10 years of age, 90 to 100% of the kids would have already been exposed to human metapneumovirus or HMP virus. And pediatric hospitalizations tend to happen in 5 to 10%. So it is more of pediatric hospitalizations during winters when they are exposed. If 100 people, 100 kids have this, 5 to 10% may need hospitalization. And if this metapneumovirus, this is all as per the literature, if metapneumovirus affects kids less than 6 months, there is 3 times increase in the risk of them being hospitalized. So the younger the kids, more severe can be the manifestations needing hospital admission. And so would be the case in very elderly or more frail patients or with comorbid patients, which we all know. So this has been time and again re-emphasized. Those are the population group that need to be little more cautious. So when you look at the core data, if you look into the PubMed and look into, so this is the largest data that we have got, a meta-analysis from France, which was published in 2016, human metapneumovirus in patients hospitalized with acute respiratory infection. So the meta-analysis was mainly to make observations as to what was the prevalence rate of HMP infections in France, and what was the pattern of that occurrence. So that's all it is. It is not to look at outcome or how these patients were. So here they took 75 studies. So it's a large body of studies they took, looking at 82,240 patients who had this, and the prevalence who had viral infections. Now the prevalence of HMP infection was 6.24%. And as you see, that was statistics. So basically, there was a statistically significant occurrence of HMP infections when you take all viral infections in a country-based epidemiological study during winters. And what they interestingly found is there is a significant increase in the infections when in a geographical areas above the equator. The farther the country is from the equator, the higher is the risk, which means the countries get much colder, like Europeans are much lower down the equator. The farther you go from the equator, higher is the risk of having this burden of metapneumovirus. So that is something which came interestingly from this study. And this was the global prediction in this 2016 meta-analysis paper. As you see, the most burden was seen. See, as you go above the equator, you had more sort of a burden of HMP, and you saw most of it clustered in Europe. And you saw few spots in India, and that occurred more in the North Indian. And if you see here, there are few spots in few clusters in China and Southeast Asia also. We had few clusters. Possibly this area revolves around Malaysia, Vietnam, so on and so forth. So this is the global sort of a clustering of HMP in 2016 from this meta-analysis that they could collate. So pathophysiology, I'm sure all our intensive care friends and any other doctor specialties would like to know, how does this, like COVID, the whole pandemic of COVID, which lasted about more than 2 years with 70 lakhs sort of a deaths that happened globally. The whole pathophysiology revolved around spike protein. And the spike protein, I'm sure if you all recall, the spike protein underwent mutations, and all the devastating effects was with the spike protein. And so is the case in HMP also, they have proteins. The incubation period is 3 to 5 days. So it has 8 genes. So this is just a genetic representation. 8 genes this virus has, which codes for 9 proteins. So it has 9 proteins. And like in COVID also, it had few proteins, but the spike protein was the dreaded one. Here, there are two important proteins which can cause the problem. So they have this attachment glycoprotein and a fusion glycoprotein. As the name sounds, attachment glycoprotein, the virus uses to attach itself to the cells. And the fusion protein gets the virus entry into the cells. Right? So, and these two get attached. So this is the epithelium, just a schematic representation. The attachment protein and the fusion protein gain entry. This is the cell surface, gain entry into the cell by attaching themselves to the integrins. These black things are called integrins. So by attaching to integrins, they gain entry into the cells. And this leads, once it enters the cells, like in COVID, if you recall, you would remember we used to do IL-6 levels. Once it gains entry into the cells, like any other virus, it causes release of IL-2, IL-6, tumor necrosis factor alpha, and interferon alpha. So these are some of the chemokines or the cytokines that get released in the cell. And it tends to attract monocytes and plasma cells, and that leads to inflammation, which typically tends to happen in the respiratory tract. So this is the understanding, current understanding as to how this virus, so it has around 9 proteins, there are 2 proteins which attach to integrins, gain entry into the cells, causes inflammation in the cells, and that leads to bronchiolitis, pneumonia, so on and so forth in vulnerable patients. So when you look at history and physical examination, it's like any other respiratory virus. There can be fever, there can be some sort of a nasal congestion, sore throat, and they can have cough. And in severe cases, they can have shortness of breath and going on to needing oxygen. Like in COVID virus, they can have nasal congestion, they can have conjunctival suffusion, but like in COVID, which the later variant that came, which had GI manifestation, even HMP virus can have nausea and vomiting. And as I said, they can cause pneumonia, bronchiolitis, and underlying disease like COPD and asthma, they can exacerbate. In severe cases, this can lead to hypoxemia and respiratory failure. That's all are the symptomology. But what is dreaded is that we don't want them to develop pneumonia and land up in ICU. And all intensivists pray that these patients should not come to ICU. In fact, I had a recent call from our commissioner asking whether there were any ICU admissions. So far, we have not had any ICU admissions. We'll pray that no one comes to ICU nor hospital. So that is our current understanding. So how do we evaluate? The only diagnostic means is by doing RT-PCR. Like in COVID, we used to do RT-PCR. Even everyone is aware what RT-PCR is. So we do this testing. So it's reverse transcriptase polymerase chain reaction to look at the viral particles, the RNA part of this virus in this test. And RT-PCR is the gold standard. So the adjunctive tests are, of course, you will do chest X-ray and CT. I'll just show the images as to how chest X-ray. So this is a chest X-ray of a hMPV virus in the kid, and it looks pretty normal. If you look very carefully, there can be some infiltrates with hilar prominence. But then if someone is like this with hypoxemia, you would go on to do CT. In CT, like in COVID, I'm sure every doctor is aware in COVID what we found. So this is the CT scan of an HMP patient. So you would see ground glassing, and there is a perihilar predilection. So there is more of perihilar sort of a cuffing and opacities that tend to occur in HMP. And this is another CT, and I'm sure these CTs don't look as bad as in COVID. If you saw COVID, you had more ground glassing, more confluent-based opacities. But here also they can have ground glassing and some perihilar sort of a opacity. So this is what has been referenced in the literature, the type of CTs and X-rays that we can see. So management of mild cases, it's always symptomatic treatment, just paracetamol and antihistamines and medications for relieving congestion. But so if someone is symptomatic and someone is febrile, I think the standard sort of a protective measures of not spreading the infections by trying to remaining at home and not being in the crowded places is the way to go. And as far as possible, it's better to rest until patient is febrile. Only after afebrile, you can possibly wear a mask and then head back to work. And distancing is important. Why is it important? Because in COVID, you remember 1 meter distance. Why is this 1 meter comes? Because it's a droplet spread. And I'll just show you what's the difference between droplets and aerosol. And most of these patients as per the current literatures, have recovered. So the deaths have been very seldom reported. So that's the good news at this point of time, unless even coronavirus was like that before it came until it mutated and then caused the severe form in the China, because we keep hearing about the upsurge of these cases in the northern part of the China. So we need to say if this is causing more hospitalization, then it means that it may have mutated and come out with a new strain with some new protein. So that's what we look at. So this is the difference between droplets. So as we know, at this point of time, HMP virus spreads by droplets. Droplets spread within 1 meter. That's why we say distancing, social distancing is needed if someone is infected, because droplets last up to 1 meter. And if it is aerosolized infections, then even it can spread more than 1 meter. And even in droplets, so there is a division whether it's a large droplet, intermediate droplet, and small droplets. Large droplets are the ones which has a more potency to spread. And why large droplets? Because the droplet sizes comes down based on the humidity and evaporation and the heat. So the colder the temperature is. So because it is cold, the droplets don't tend to evaporate, and someone who is infected tend to produce larger droplets. So the risk of spread is more. So that is our current understanding. So the droplet size is dependent on relative. This is more scientific for all our doctors. It is dependent on relative humidity, temperature, and evaporation. That's why in cold seasons, the spread of this infection is more, because the droplets don't disappear that easily. So this is our scientific understanding as to why social distancing may have to be maintained. So there are some anecdotal report in extremes of cases. They have done scientific studies in animals and in humans where ribavirin and in combination with IV immunoglobulins has been used in kids who became very sick with HMP virus. And there is one case series published in 9 patients where they landed up in severe respiratory failure and they had to use ribavirin and IVIG, out of which only 2 recovered. But this is all at a very nascent sort of anecdotal sort of a report early on. So don't jump and say that these are the modalities, but this is just reported in severe case in children, in neonate and in children, where they had to use it as a desperate measure. So if you ask me, should we take precautions now? HMP virus, there are reports of surge in China, although we don't have a core data as to how many cases are there. WHO, I was just Googling, WHO has come out with an advice, because in winters there is going to be surge in the infections. It says that if someone has symptoms and if there is a reported increase in the cases, one needs to take precautions. Precautions is the standard COVID precautions that when you're coughing, you have to cover and make sure the droplets don't spread. And any infected patients has to use the mask so that they don't spread the infection. And 1 meter distance is important because the droplet spreads can be mitigated, and washing your hands. And if you are symptomatic, if you have, so you don't spread the infection, try to remain at home at least until you become afebrile. Definitely, this is something which one should possibly keep in mind. If you are traveling in a crowded places, it is desirable that you wear a mask, especially you wouldn't know who is infected, especially when there are reports coming around that there is surge in the infection, and no handshakes or hugs. So these are the standard COVID precautions, which possibly you may have to keep in mind. But as of now, it is very clear that conventionally and historically, these HMP virus has not led to any devastating effects with increase in hospitalization, increase in death. But we hope and pray it remains the same. But we have to be vigilant though, and try and adopt all the standard precautions that which we adopted in COVID, because prevention is better than cure. But there's at this point of time, there's no cause of alarm. So it's more of a scientific sort of a data we have at this point of time about the pattern of this HMP virus. So that's about the whole HMP. So there's not much you dwell, how much ever you dwell into the literature. This is all we have at this point of time on HMP from the scientific standpoint. So just a simple MCQ questions for, it's a very simple questions just for all my trainees who are sitting here. So I have around 5 trainees. So very simple questions. So which of the following best describes human metapneumovirus? Bacterial pathogen, a DNA virus, an RNA virus causing respiratory, a fungal pathogen. Dr. Mega. Okay, so it's a C. So it's an RNA virus causing respiratory tract. So human metapneumovirus is a member of which viral family? Paramyxoviridae, Coronaviridae, Orthomyxoviridae, or Picornaviridae? Dr. Shastri. Okay, that's good. Paramyxo. Now it is categorized under Pneumoviridae. So it was Paramyxoviridae. So now categorized under a new class called Pneumoviridae. It has A and B strain, and A has A1 and A2, and B1 and B2. Which age group is most commonly affected by severe hMPV infections? Adolescents, middle-aged adults, elderly individuals, and young children, healthy young adults. Dr. Patil. Elderly individuals and okay, good. That's all. That's all very easy questions, but just to scintillate our thoughts once we're looking into this. What is the primary mode of transmission of HMP? Bloodborne, contaminated food and water, direct contact with respiratory secretions, vector-borne through mosquitoes. Dr. Pratibha. Very good. So it's a direct contact with respiratory. Which of the following clinical manifestations is commonly associated with hMPV infection? Skin rash and joint pains, diarrhea and abdominal pain, fever, cough and wheezing, muscle weakness. Anyone can take this. Okay, fever, cough. Which diagnostic method is most commonly used to confirm hMPV? Blood culture, chest X-ray, RT-PCR antibody. Good. So thank you, friends. So hope this video just gives you a scientific insights into our current understanding and the data that we have at this point of time. So we'll hope and pray that it just abates and we don't see any more surge in these cases. And last thing we want is them to come into hospital and coming to ICU. So request all of you to submit your valuable work to Journal of Acute Care, and you can of course visit my website. So thank you, one and all.